49.
All right,
Thank you
so
for
I'm
that.
starting to
All right.
record the session just so you're aware.
Yes, starting recording.
Yeah. That doesn't mean you have to be all quiet.
Instant silence when we know we're recorded.
Oh, hi, Sandra. Hello, Sandra. Okay, so we're going to start, right? Is Byron going to open?
I think so. Well, that was
Yeah,
the
that's
idea.
the plan.
Byron?
That was the plan, right?
Yes.
Okay,
Andrea, do you still know where Byron is?
He's there.
I'm here.
Okay,
I'm
good.
here. I'm speaking. So, good morning, everybody. We made a decision early on to cancel I think we were amongst the first at Harvard to cancel seminars. And we're a little late in starting up by Zoom, but I think we've all gotten accustomed to doing it. And it seemed like a really important time to gather people together. Already we can see that this has the advantage of people all over the world, people who've been a part of, able to join in a way that when we would hold it in person, hold the Friday morning seminar in person, when we would simply meet together in person and then tape record it or audio record it and hope someone might listen to it, never really brought us together. And so this is actually really interesting. And I'm sure that we will, whatever happens, we will use this method into the future. And we talked about, we have only a few Fridays left. And we talked about today having the clinicians in our group simply talk about what their experience is like. I think it's important to hear from people who are practicing clinicians to talk a bit. Next week, I hope we will talk with people from here and there around the world about what this experience is like in quite different places. Lou, we hadn't asked you, but I hope you'll tell us some things next week. We'll talk a bit about what's happening in Brazil. I know there's a lot of interesting things happening, and you're concerned about what's happening with the Amazon communities, etc. So I think we'll do that next week. And then the plan is on the third consecutive week, we'll have people talk about what Partners in Health has been doing in case finding in the Boston area. So that's a general plan, and we'll announce more details as this goes forward. But I want to just take the moment to say welcome to everybody, and it's really fantastic. Already we've done what I hoped we would do, which is just to see people and have this opportunity. So I think I'll stop at that. Turn it over to Mary Jo to say a word, then to Michael to say a word, and then we'll start talking. We'll ask our clinicians one by one to speak. Mary Jo, you have to unmute.
Unmute yourself, Mary Jo.
Okay.
Sorry.
Does that work?
Yep.
Am I speaking?
Yeah.
You can hear me. So thank you very much for getting on. And at first I thought, oh, when Iman sent me what was in the middle of the night, just after I got home from Indonesia and I was jet lagged, a note that said we should get together on Zoom, I responded, no, no. Thinking of the little bit of difficulty I had when we were doing a little bit of Zooming in Indonesia before we left. But since that time, I think I've been won over to be able to see your faces, or your names at least, and to think about this community in many different ways. And we'll be hearing from not only our clinicians, but also you. And I think, Sadek, you're going to be monitoring the kind of discussion, right? Where people can ask questions and it'll be arranged as a discussion. So I thank all of you, and thanks Sadek for doing the technology on this. It's delightful to have you with us, and we really appreciate that. So welcome folks to Friday morning seminar. We're starting just about at the time we normally do, somewhere around 10:15.
So let me just add my word of welcome to everyone. It's really fantastic to see everyone on more or less one screen. Yeah, I don't have a whole lot to say except that we've got a huge amount of expertise in our little community, and we can call on a few more. I just want to maybe welcome Rob Myers if he's here. He's a structural biologist at Harvard and can help keep us sane on the science side of things. And maybe we can hear from him a little bit later about vaccine development in particular. It's great to see people distributed around the world. This is something that we can't normally do in Friday morning seminar. So let's begin.
Wonderful. So maybe we will go then and start with our presenters. Byron, Mary Jo, do you guys have anything to add, or should we go on?
No, I think let's go ahead. We have it listed out. So let's begin with Antonio. Antonio, there may be a very few people who don't know who you are. So say just a couple of words about yourself. Antonio's been a member of this group for so many years that most anybody who's on now knows Antonio. But Antonio, say a word or two. Mary Jo and I began having telephone and email conversations with Antonio about his experiences of working in the Cambridge hospital system. And, you know, I think simply the process of reflection by clinicians about what their experience is like is worth hearing from. Images like being on the front line, et cetera, are reminders of the kind of situation that clinicians are working in. And I think that was the reason that we thought we would begin this way. So Antonio, welcome.
Thank you, Byron. And this feels a little bit like, I don't know, must be like when you die and then you go to heaven and you say, oh, hi, you have everybody who, oh, I haven't seen you so long, well, but not that long, but I am a psychiatrist, and I have also the background of being a primary care physician, and I right now dedicate myself to geriatric psychiatry in an inpatient unit in Cambridge for older adults, and so one of the things that through the years, usually my reflections are about the work that I'm doing at the time, and also I had done some work in areas in Peru that were affected by the civil war several years ago, and how it affects the population. But now my reflection is going to be about my work, the work that I'm doing now, that I have been doing for the past 8 years at this point. I have to say that we were warned that something was coming. One of the first things that they told us, just keep your badge with you because you're going to need it. We were not very sure about that. It's like, in case, you might be the, people that you need to be in the road, and they need to ask you why you are in the road. But these things are going to get bad, they were saying. But until May, I don't know, March, before the 21st, that things start to really close down, and at the beginning I really did not notice much, other than I could not meet with my patients face to face. I mean, there are 16 beds in my unit, and all of the patients had to be actually isolated. They had to use a mask And they have to be, they could not go in the hallways. They could not walk in the hallways because of the fear of getting infected. Actually, there was one gentleman that was positive. So everybody was putting alert, the staff, the patients. So you can imagine a unit that is for patients who are, older adults that are either depressed or they are anxious or they have dementia, for them to be isolated and not be able to really get out of the room. It was quite distressing. And we discharged a few patients that probably would have been discharged 1 week later. But one of the things that then I started to also notice with my outpatients is it was an interesting aspect, is that patients of mine that have seen me for depression, for treatment of depression, and I'm talking about my outpatient private practice, in which I, prescribe medications and also do my evaluate of psychotherapy. And patients who had this chronic depression, patients who had become disabled, sometimes disabled by medical reasons, like 10 years ago, and as a consequence became depressed. And actually, that first week of the isolation, patients like those actually felt better. I mean, there was this sense of, many patients were like, I was expecting they were going to say, oh, it is terrible. No, it was actually, you know what, not that bad. And one of the things that they had at least noticed in that week is that I have in particular this patient of mine that actually had to retire because of, early because of his bipolar disorder. I mean, he was a very successful neuroscientist and he had to stop working. But one of the things that all these 10 years is like repeating and repeating about, I'm not being productive. I feel guilty because I'm not producing. I should be like this. I am not doing this. I'm not, and that has been relentless in him. However, this week it was, you know what, he was, doctor, for the first time, kind of somebody kind of appreciated my words of, they were really, a friend of mine was freaking out, and I was like, these are moments difficult, but they will, you will endure them. And they said, and people were saying, wow, thank you. I mean, where did you get those kind of words of wisdom? And they were saying, he was saying, well, it was from my own experience. I mean, and I said, what's happening is you have been exercising on this for a long time. You have been living in this for a long time. And yes, you have actually many values, that you have forgotten about, and maybe the value of even listening, even the value of even understanding, even giving advice. But, that is not the value that also you yourself have been, in your mind. It has not been like, it has been, I have to produce. And suddenly it is in something that is relatively not productive. Suddenly they are saying you are great at that. And he's actually very good at that, and feeling this value, that he had forgotten about. The other is the issue of that for the first time in a long time, the world was in sync with him too. I mean, he was before an alien, strange, and then the whole world was kind of going in other direction, and suddenly everybody was also stopped. And he was not the only person that started to tell me about that. Patients with severe anxiety or depression telling me that. Now, I have to say that after probably 3 weeks of being, then I then start to hear, the depression of the past again, So it was I thought, oh, wow, this is a great opportunity. I mean, there are some, and this is probably that maybe we will observe later, but it is something that there are some patients that, if they have actually an opportunity, something that they rediscover, they probably, if they continue on that, it might be a protective factor, even something that it can be used later in therapy. Well, the other issue was my personal reflection I have to say that I also seeing one patient in the unit got infected, and then with all the precautions, everything we had to be, to be careful with, because I realized I was the one that could bring the virus to my patients, and I am the one who could bring the virus to my family. Then that to be so careful, and so that situation that I have not put any attention in the past, or much attention, but this time fear. And I was actually I realized I was afraid of coming to the hospital, and then I was asked to see in one occasion consultation in the medical floor. And I have to admit, when I am going, it was a young woman who tried to drown herself in the fresh pond, and well, she was in shock the night before, and she was somewhat confused. And actually, they admitted her because with this kind of confusion, what about if this is a toxic metabolic encephalopathy from COVID-19? And admitted in the medical floor, a young woman, but I was like, oh, here, this overreaction. Now everybody's overreacting. Of course, when I am approaching, I see that the last name is Chinese, and not only young woman, Chinese, and at the same time, I say, well, I just maybe, hopefully will be, an Emily, or no, it was a very Chinese first name. And I said, oh, inside me, I have to say this sense of fear, I know, that it comes to me like, it does not make sense. You cannot, you cannot judge, you cannot, but it was this immediate, can she be less Chinese, please, and how long she has been here, oh, just a few months, and then it's like, it's the first really patient that potentially could have been positive that a few minutes before I was like, what the big deal? Everybody's like, everybody's is overreacting, or everybody, or the other is like, of course, I don't know why people are being so, kind of this stigma about if you are Chinese and all. And then finally, I find myself with that reaction, and then I do remember entering with this gear to see the patient and realizing how much she was isolated. Part of what had triggered the depression was the isolation in the past few weeks. And no, she did not have COVID-19. She was extremely isolated and needed somebody to talk with. And I remember kind of in my mind these two. One is like, get out of here as soon as possible. Just make the diagnosis, whether is she depressed or not, suicidal, does she need to be hospitalized in a psych unit? Quickly, make the decision. And the other is to listen. And they were fighting, with myself. The other thing that I then also, as I encountered that, it was also this re-encounter with the reasons why I went to medicine, why I became a physician. And I went straight back to my intern years. Actually, my first call that I was in the pediatric floor. And I remember as an intern, the second year resident sent me upstairs to sleep the first part of the night. And then he will call me when he needed me, or, it was time to change. And I remember him calling me around 2 a.m. and it was still 1 hour before I was supposed to go down, and saying, I need you down here. Come, there's a kid with pneumonia. Okay. So I realized, I love sleeping and waking up at 2 a.m. and it was cold. It was not a very nice hospital in the middle. It was cold in Lima, very humid. And coming down, and I saying, this is so uncomfortable. And at the same time, I remember starting to cry. At the same time, realizing this is also very beautiful. What is happening now? It's true. I am, I am in love with my career. I have been always, but then I have to say, years came, and now encountered this fear, these two things in my head. For some reason, that makes me make it more beautiful, in the sense that there is a little bit of this dilemma of really that is not something superficial I have chosen, but also if there is that I have a choice to, And so realizing this, what I was commenting to Byron and to Mary Jo is this kind of the beauty and the fear, of this. And so, I mean, these are just initial comments that I am having, about this. I mean, but then also it comes, of course, one day that still I don't want to come to the hospital, and I wish that I'm not too close to somebody that has the infection, or if I am, what do I do? I mean, I know what to do, but it's like there is this fear, or the other is, I want to be involved with palliative care. I want to be involved with, I mean, the saddest thing is when people are dying alone, and it's like how to be involved. And at the same time, it's like, no, you don't want to go there. You know what? You do not want to go there. So why? So I find myself in this kind of dilemma, internal dilemma, but at the same time, which also makes me think about really why all this? Why am I doing what I'm doing? Also, I think at the general level, at the medical systems level, I mean, I think this is going to be, I don't know exactly what, but it is removing every single aspect of, from the economics to the ethics to the, also to the reason of why we're here too. I mean, this is an important time for that. So I leave it there, just, for the others to continue. I would like to really hear their experiences too. Yeah.
Thank you.
Byron?
Thank you, Antonio. I think that's, having been in conversation with Antonio for a number of years, I know he worked closely with Mary Jo on the book that they did together, but also listening to Antonio's stories. It has been a pleasure over the last weeks just to listen in as you reflect on what your experiences are like. And I know you'll look forward to people asking you more questions. When we were talking about doing this, Antonio said it would be really nice if people were able to ask questions, so that would stimulate his thinking further. But I think what we'll do, given our time frame here, Alistair Donald is in court and will not be able to join us, but we'll ask Michael Mike Nathan to say a few words about his experience also.
I'll try and be brief. I just took a few notes and I could talk for probably 20 minutes. First of all, I'm a primary care doctor at a health center affiliated with Mass General Hospital. And I do work with our palliative care team, doing these serious illness conversations that have become very important at the moment. And I also do some work with a coaching program at the hospital, and I'll talk about that briefly. My own practice is with a highly varied demographic population from suburban to Chelsea, which is currently one of the hardest hit areas in the country. It has among the highest per capita incidence of COVID, and I'll say a word about that. So just a brief update for those who, you may are at the risk of saying something you've seen in the news. MGH has one of the largest patient populations in the state, nothing like New York, and it looks like we will be nothing like New York City, which is, we're grateful for. As of the last time I saw, which was yesterday, there are about 350 COVID positive patients in the hospital. There are 150 of those that are in our ICUs. And that number has stabilized over the last week. So it looks like we will be able to meet the current Boston surge, and that's true throughout the city. I think only Boston City Hospital, Boston Medical Center, ran out of beds at one point last week, and they have since been able to clear some. And there is a tremendous coordination in the city between the institutions, which is not always the case and isn't necessary in usual times. It's gone from a very competitive environment to a very collaborative one. So I practice in Revere. We have many patients in Chelsea, and there was a rapid study from one of our pathologists of just randomly testing people on the street in Chelsea, and the current tests test for active disease, so they would potentially miss somebody who had disease and cleared. But out of 200 people they stopped on the street and tested, 60 were COVID positive. So something like 30% of the population in Chelsea is affected, and it may be higher. Chelsea is a fairly dense urban area. There are a lot of both documented and undocumented immigrant populations. They are largely employed in service jobs that they often can't leave, and are often housed in very constrained environments. So I was on call last weekend, and at around 7 p.m. I got a call from a family, from we'll call the father to try and separate the generations. The family is grandparents, their daughter, her husband, and 3 children, 3, 6, and 8. And the husband and grandfather had gone to get tested the day before we called in, had been positive. The wife, they were tested because the wife was in the hospital sick with COVID, and the grandmother was also sick but hadn't yet been tested. The 3 kids were well at that point. So at 7 p.m. I get a call that the grandfather, who had been seen and diagnosed with COVID pneumonia and treated with antibiotics, was either not tolerating the antibiotics well, or because of the virus was vomiting and couldn't hydrate. We tried to hydrate him at home and it failed, and we sent him to the hospital. 5 hours later, I got a call from the father, the middle generation, that he had been short of breath for 5 hours. He felt the grandmother was too sick to take care of the children, and but had to go to the hospital. And I'd spent a lot of time actually working on it with the emergency room, and they was advised to come in with the kids, which he didn't do. And later in the day, the grandmother was also admitted, and she did bring in the children. The somewhat miraculous part of this story, and the thing that makes me feel really good about our institution, was they just admitted everybody. And the father is co-housed with the kids, so that the kids are not on a pediatric floor, and the pediatric nurses had set up the room to be very homey. And it was a lovely resolution. So I will speak for a moment about hubris and pride. That gives me a lot of pride in my institution and the way we have stepped up to the process, and the kind of research that's going on, and the compassionate care, and the thoughtfulness with which we had planned for crisis management should we run out of resources, though there has been some back and forth about that, and probably would continue to be if we needed it. It just makes me very proud, and it also puts me as a clinician at the edge of hubris, because it's very easy at a Harvard institution to develop some hubris. I think I'm rightfully proud, and I think I'm proud of our city. The first thing that happened in middle of March was that all of these big research institutions in the city basically formed a collaborative to research what was happening with the virus, what was going to work diagnostically and therapeutically. And we've been more or less constantly updated about progress. And it's amazing how much has been done in just a month. I do want to share one slide. This is actually a copy of an email. And this is one of the downsides of the current environment.
Yeah.
So I've shared this a bit. This is actually a mock New England Journal article from people who probably are the real docs in Chinese. Most of this is probably real, but it purports to compare business as usual, which is something like leave me alone and let me do my job as the default, and interminable meetings as the intervention. And interminable meetings were not found to be beneficial in the treatment of COVID-19. A few other things. So I've been working actually harder than I've ever worked, and I am not seeing patients physically. Unlike Antonio, I've not been called into the hospital, partly because I'm 64 and have a little asthma, and my practice leader has suggested that I don't go into the respirators. That leaves me with some feelings of guilt, but not very strong. That I'm spending a tremendous amount of time. We have probably 4 important meetings a week, grand rounds for medicine, which you can watch online if you want. They're in the public domain, as well as town halls. And I have these coaching and palliative care groups that I'm working with that each have meetings. So I could easily be in meetings for 7 or 8 hours a week. And I've started to fall behind in my meetings. It's just not possible. Telemedicine is surprisingly effective. Most of what I do in the office does not require a physical exam. I have so far, because my patient population tends to be older or under-resourced, not been able to do video visits, which many of my partners are doing. And I'm looking forward to that because I think there is a kind of connection that happens. And I have seen clearly on the meetings that there's a sociality to Zoom, as we're discovering here in the opening and then during this process, that is quite powerful. It's not the same as being there in person, but it is a presence with each other that is, I think, very important. And I think I'll stop there. I could say more if people are interested about the Serious Illness Conversation Project or our coaching project. The one thing I will say about the coaching project is there is so much attention to professional well-being among providers, social workers, people who are doing direct patient care, and the potential for burnout, that there are probably 7 or 8 opportunities for doing something reflective, meditation, online yoga. There's actually probably more than 8. And we are one of them. And so we get actually almost nobody to sign on to our calls, partly because I think people are confused by how much is available. And we've decided that part of it is that in the midst of the peak, that people really don't feel like they have time. And we're very interested to see what happens as things start to calm down. And I will say something else about the peak, which is, so we're in the midst of a peak, which looks like it's going to be a longer and shallower peak than we had expected. And so to talk about the fact that the patient population at Mass General is stable, one of the ICU leadership folks on a call yesterday said, it's not stable. The number is stable, but we admitted and discharged 30 people from the ICU yesterday. So their numbers are stable, but the transitions are radical. People get sick quickly, they eventually get better quickly, and it's a tremendous amount of work. And so we'll see where it all goes. I'll stop there, I think.
So thank you, Michael. That's really terrific. Again, I think we'll just move ahead and give everyone on our list at least a chance, and then from there we can open up and go back to have a conversation. The next person on our list is Catherine Peeler, and Catherine, amongst other things, is a master's, doing a master's in medical anthropology, but is also at Boston Children's, and so this is a chance for her to talk about her experience. Catherine, join us.
Hi, can you all hear me?
Yes.
Yes, we can hear you.
Okay, great. Okay, so thank you. So I, just to give a little more background, I actually work in the pediatric ICU at Children's, and I kind of have 2 hats. So I do that as my paying job, but then probably I spend equally, if not more time, also volunteering with physicians for human, and I've actually done a lot of work around COVID related to that in the care of children. So I'll just kind of briefly describe both. But from the children's side, I would agree with Michael. I think the kind of response from Boston in general has been very impressive. I spent a lot of time talking to a very close friend of mine who's an intensivist at MGH, an adult intensivist, and it's just been pretty remarkable. From the peds side, as I'm sure most of you know, COVID it definitely affects children less than it affects adults. However, we do see it, and I've seen really critically ill children. We've seen critically ill children with COVID who've been ventilated and paralyzed and sedated, who have underlying diseases. And then we've also seen totally healthy kids who end up with myocarditis, you know, on ECMO from COVID. There's one right now in our cardiac ICU. So it's much less, it's not like influenza where like they kind of come in droves. It's less common than that, but it does exist. And so it's in a weird place to work. So almost all of the pediatric hospitals have essentially shut down and turned over their ICUs and a large part of their floors to adult care. And as a freestanding hospital that typically doesn't take care of adults, although we do, we are now kind of the default. We're definitely the PICU for the city of Boston for the most part, and then we also have we're largely the NICU and somewhat the peds floor. And so on the one hand, it's been somewhat empty because we've canceled all of our elective surgeries and things like that. But on the other hand, everyone who's there is very, very sick. So you know, normally my census is some kids who are fine, they're like a little bit sick in the ICU, and then a couple are critically ill, but now everyone is also waiting a long time to bring people in because they're scared. They don't want to leave their house. They don't know what it means, and so arriving sicker than they usually do because they probably should have come in a day earlier. So that's been an interesting phenomenon. And then we've also seen kind of piggybacking on Antonio's just the psych stuff. I've actually had a lot more psych admissions in the last 2 weeks, and I don't know. It's interesting. Some have had COVID and some have been there for ingestions or other suicidal attempts. And I don't know if it's that. So certainly mental health is known to, mental health issues are known to be a risk factor for infectious disease. That's been seen in other things across the board. And some people have postulated that, you know, there's a cortisol response, and so you're stressed, and so you're at increased risk. But I think on the other hand, you know, you could think about whether or not social distancing is somewhat protective versus whether or not it actually lends more to depression, especially in teenagers. We have seen some who've actually written suicide notes about how lonely they've been. So that's an interesting thing that I've noticed. And then just from the perspective of being a physician there, it's a very you know, kind of, Antonio, you were saying in terms of like being scared to go to work. Like I normally never dread going to work. I'm fine going. I don't mind if you're critically ill, like that's, you know, what I signed up for, but it's a very uncomfortable feeling to walk around the unit knowing that everything takes a little longer. So if someone is arresting, I can't just run into their room and start helping them. Like you have to take the extra 30 seconds to make sure your gear is on correctly. And that is, I can't, like, if I ever have time to sleep at night, I can't because I'm so nervous that it's going to take me too long to respond. And so I think everyone kind of has that heightened fear. It's also a bizarre feeling where you know that the people who are most at risk in the hospital are actually the staff, because I'm not particularly old, but certainly I'm at more risk of getting COVID than our patient population, just statistically speaking. So it's just kind of a bizarre. Everyone's kind of on edge, even though we are not Mass General. We don't have 150 people who are ventilated with COVID, but it's just an interesting place. There's also a lot less room for error. You know, like when you intubate someone with COVID, you have to kind of do it immediately because you're trying not to spread the pathogen everywhere. And so the kind of less room for error also, I think, makes everyone feel quite heightened. Another phenomenon that I've seen that I think is interesting is that I obviously at Children's have a lot of patients who have chronic comorbidities, and some of them have really been ready to go from whatever they were there for, and they've kind of lingered. And if you spend time talking to their parents, the reason why they're hesitant to go, if you kind of really take the time to talk to them, is that they're scared that if they leave, that there might not be room for them, or that if they go home, the ambulances will be too busy picking up adults, and so their chronic kid is going to get shuttled to some outside community hospital that may be a great hospital for an adult, but may not know their kid's super random rare diagnosis. And so they're scared to leave and kind of give up their bed for fear that their kid might not be able to come back. I had to spend a lot of time counseling families of chronically ill children, kind of trying to reassure them that, you know, we're always there and they can feel safe going home. And it's probably certainly safer to be at home than it is in a, we are actually, my unit is the COVID unit. So it's probably safer than sitting around a bunch of other people who have COVID. And then just kind of shifting gears a little bit, the other part I want to talk about that I spend a lot of time doing is, you know, in addition to the kids who are inpatients, I've been doing a lot of work writing expert declarations for various cases. Actually listening to one in an hour that I wrote a declaration for. Give me 1 second. Hey, bud, can you go back downstairs? So my kid is building a fort. Both for the, there's a big legal case to try to get children released from ORR custody. So the Office of Refugee Resettlement, you know, where unaccompanied children stay, who all have sponsors. And as you probably read in the news, there have been a lot of outbreaks of COVID within those units, both of staff and of children. And there's another hearing today at 1 p.m. Eastern time in California about that. So I've been working a lot to try to get kids released to sponsors that have already been screened and we know they're safe. They're mostly their family members. And then also working on a separate case, trying to get families released from family residential centers. So the 3 family detention centers in the United States, the 2 in Texas and the 1 in Pennsylvania. And I have to say, I don't know if they're all, certainly people have started to get released, which is great. But the other thing is that even just the pressure of basically kind of constantly writing about it and having these legal cases, they've really stepped up the actual, the stuff that they have available at these detention centers. So it's clear that they did not have, everyone did not have soap. Everyone did, there were a lot of really terrible, we already know the conditions are bad, but the conditions were particularly bad for a pandemic. And they really have done a much better job releasing people, housing 1 family per room, monitoring people for symptoms, cleaning doorknobs and you know, light switches every hour. And they've all been videotaped now, so you can kind of tell it's happening. So anyway, that's just been an interesting separate phenomenon, but there's just a lot going on, and I'll kind of stop there.
Thanks a lot, Katie. So I think this is really interesting. We're just getting this kind of range of experiences, and I think it's quite important. And we have with us Iman Rushdie, who was a PhD student of ours some years ago, is currently practicing as a nurse in Emory University Hospital. And we were in conversation with her actually about coming up for what was supposed to be the May 1 celebration seminar for Mary Jo. But Iman, we'd like Iman to talk a little bit about what her experience now as a clinician is like. So join us, Iman.
Iman, you were on mute. I just unmuted you in case.
Okay, am I heard
Yeah,
now?
you are there. Yes, we hear you.
Okay. So usually people think of changing the world when they're young and they grow out of it, but I'm still the same. I'm still going to change the world. So among the many hats I wear, well, medical anthropologist and oncology nurse, I also joined the disaster preparedness team here in Atlanta, Georgia, and I've been active with them since 2007. And then I heard about COVID as early as November, December, when it started breaking. And I said, okay, all right. And then I thought, oh, if it makes it here, if it ever becomes a disaster, we're going to be prepared. And comes January 31st, and Health and Human Services declared an emergency in the United States. And then March 1st was a very important day, not only because Donald Trump announced that now the United States is in a state of emergency, but that's exactly when the toilet paper disappeared from the country and was stolen from Emory University Hospital along with the masks we had all over. So, and then a week later, we didn't allow families as part of the restrictions and the physical distancing that we were all practicing. And now we recycle the masks. I've never imagined that one day on an oncology unit, I will be asked as a nurse to use my mask for a whole week. Just a mask that I'm always asked to throw away in the patient's room before I get anywhere else. I have to wear for a week, and I'm not fathoming this right now still. We started getting donations from the community, all these fabric masks, because we're saving all our resources for the COVID units. So what's happening now at Emory is I work in the oncology unit, which is the new building. And the COVID area is the old hospital, and they are in certain floors, and they're very restricted and closed. They started actually to recruit nurses to be part of that team as early first week of February. The essential team or the solid team of nurses came from the Ebola team, which was working diligently with CDC in 2015. And then there was a second group. Well, they said, well, probably you won't be called in, but it's good just to be prepared and have a backup. Well, this second group has been working there for 6 weeks solid now. We were short. Not only that, I mean, they started actually floating nurses who didn't even get the initial 5-hour training that the quote unquote specialized COVID nurses got. We're expecting more to come because the governor of Georgia is opening the state as of today. And so he said he's allowing, for some reason, small businesses, and that includes manicurists, hairstylists, you name it, to function and open their doors. And so we're expecting those rates to increase. Right now, as we speak, we have 64 patients, and that's between ICU and regular floors. Emory has great capacity to get people off ventilators. I don't know how they do it, but most people who died actually didn't die on a ventilator. And we have 3 deaths so far that I know about. The stressing things for the nurses, first of all, you go to the hospital and you have no idea what to expect as a nurse. If you're not working on a COVID floor, you might be floated to a COVID floor. If you are officially working on a COVID floor, you have no idea what kind of PPE you're going to wear. So since the crisis started, our PPE changed. There are different levels of PPE, and it changed from advanced PPE to others back and forth. And everyone requires certain amount of masks, etc. The N95 that everybody is running to grab now in the country and elsewhere, but you really don't know. The other thing that's more causing of anxiety is when the patient comes to the ED for screening. All right, so for that patient to come to us on an oncology unit and bone marrow transplant unit, where most of our patients have 0 immunity, they have to go through 2 screenings, not 1, of COVID. And that's the rule. However, this rule gets broken a lot, not to mention that while patients are being ruled out, they're actually staying on the floor in non-negative rooms. So usually we put them in negative pressure rooms, and these are very similar to what TB patients will be placed in, but that's the case. I will never forget one time, one of the oncologists had to do direct transfer for a patient on the bone marrow transplant unit. And 20 hours later, we discovered that the patient actually tested positive for COVID. The patient was immediately transferred to the COVID area, and just a group of us nurses, I mean, there are 2 floors of oncology at Emory, and that's divided between medical oncology where I work and then hematology and bone marrow transplant. We just, a bunch of us went in there, got on our knees and just like cleaned the whole floor with Clorox and everything. Because I work night shifts. I actually just came back from one, and there are no custodians at night shift. We don't have as many resources. The other thing that's stressful for nurses is when you have a shortage, there is no recognition of acuity. I mean, people think of numbers, and that's true of any hospital in the United States, not just at Emory, but if you're short and 2 of your nurses are going to float to the COVID floor, you are a nurse, you are a custodian, you are a respiratory therapist, you're a tech, you're everything. You do everything. The nurse just absorbs all these roles somehow. And you're still expected to finish on time, start on time, and have a full load of patients. And you are also a clerk, you answer the phone, you are everything. And this just puts extra stress on the nurse, not only in the COVID area, but also outside of it, especially in oncology units. The symptoms of COVID and the symptoms of patients who come with symptoms from chemo treatment or immunotherapy treatments, etc., are very similar. I mean, everybody comes with shortness of breath who had chemo. Everybody comes, like lung cancer patients, they come in coughing and wheezing. And you have all those people who have also COPD, nausea, vomiting, all the symptoms that are similar to COVID. So cancer patients are very fun. They tell you, well, we always do social distancing since we got cancer because of course their immune system is low and they do that. And very few of them actually tested positive, which I find extremely interesting. The other thing is, it's interesting that we started experiencing the shortages of supplies, and we get the heads up about how to economize on everything, including the lines for the infusion since December, because of course, when the outbreak happened in China, they didn't export as much. And that's when you realize how much we import from China. And it happened just at the time when we changed our infusion pumps. And so we have the lines, but we don't have certain other parts of it. And so as of December, we actually felt the shortages coming up and creeping on us. The other thing that I'm actually writing a book on is the whole idea of work ethics and nurses. I'm working on a book called They Made Me a Criminal. And I'm looking at COVID-19, how this pandemic actually brought back the practices that we should be doing in nurses, but we aren't doing them because of certain pressures that are imposed on the nurse from the institutions and other issues I'm not going to go into right now. The other thing that that I like to, that's very, very important, affecting all patients, COVID patients, cancer patients, is the fact that no families are allowed means more FaceTime with everybody. And there are very, very serious decisions that need to be taken, like switching a patient from full status to DNR, for example. And imagine having to take that decision in the absence of actual family. There is a rule right now that even if the patient is dying, we're allowing one family, this is one family member only, is allowed to come and be with that patient, where usually at the time of death, we open the door to all the family members to come. And so these are serious changes. And I was spearheading this whole thing with Zooming, and I found it really important. It's like, you can still keep in touch with your loved one on the phone. And of course, the patients came without their chargers, and then we had to come up with all kinds of stipulations in order to have the families drop certain items to the patient so that they can connect with them. The other thing that I also found interesting, while the patient is being ruled out, not all doctors, not all nurse practitioners, but like pharmacists and other people started assessing the patient online, while again, the nurses and the techs had to be in the room at all times. These are the things that, that I wanted to address. The other thing, though, that we're taking great advantage of is our proximity and close work with CDC. So the initial group of nurses was trained by CDC nurses. CDC itself funds a portion of our ICU units, because at all times we have to keep 2 beds for them for Ebola patients. And so they're very, very involved with us. Since February, they've been conducting their clinical trial on trying the Ebola antiviral medications on the COVID positive patients. And these trials are still ongoing. And maybe I should stop there. Thank you.
No.
So really interesting, Iman.
Yeah, thank you.
Yeah, absolutely terrific. It's great to see Sylvie. Hi, Sylvie. So nice to have you. You're supposed to be here with us, but here you are.
Yes.
But from Switzerland. So tell us what your experience is like there.
Hello, can you hear me?
Yep.
Well, okay, perfect. So let me say good afternoon from Switzerland. I'm joining you from Basel today. And I think it was interesting for me the way how you describe the situation in the US. So I think I would like to share my experiences and reflections from Switzerland. And I thought, and actually I just have to introduce, I'm a gynecologist, obstetrician, and medical anthropologist too. So I think I would like to take that lens to share my experiences and reflections on COVID-19 with you, like according to that. So I think at the beginning of the pandemic, I was checking the New York Times coronavirus map on a daily basis for tracking the global outbreak. For long, I think you all know, China was in the very top and Switzerland was among the 10 most affected countries worldwide. So at least according to available data. Today, the US is on the very top, as you know very well too, and Switzerland dropped to rank 15. So in the Swiss media, the reporting of the data has changed. Beforehand, they talked about the number of cases tested positive and the number of deaths, but now it rather includes the number of infected persons who recovered. I think therefore the introduction of these new figures reflect a kind of turning point. However, to give you an idea about the situation in Switzerland itself, I would like to compare it with New York City. I think both with a population around 8.5 million. While New York City has more than 142,000 cases right now and more than 10,000 deaths, Switzerland has more than 28,000 positive tested cases and 1,200 deaths. To say it in other words, Switzerland has only 1/5 of positive tested cases and 1/8 of deaths compared to New York City. So I would like to say such a comparison has for sure its limitations, but I think it gives you an idea of the context where my experience with COVID-19 is located in the following. So when we talk about Switzerland itself, the Canton Ticino at the Italian border, I think, and the cantons of Geneva and Lausanne at the French border, they are the ones who are the most affected ones. Myself, I'm working at the biggest of one of 5 university hospitals in Switzerland, located in Bern, which is the Swiss capital. I think you talked about the number of cases you have on the ICU, but we have only the intensive care units of Ticino and Lausanne. They are really occupied, while the other ones that just have cases like 4 or 20, but they all have empty ICU beds available. So I think it's very different. So far, I was not in touch with a COVID-19 patient at all. At least I have to say, at least so far, according to my knowledge. And but I was working all day, 12 hours or more in the hospital. I think mid-March, Swiss hospitals start to work to implement measures to address the challenges caused by the pandemic at full speed. So one expression was frequently used at the time, and I really like it. We called it a rollende Planen, which I can translate in a way like planning on the move. So everything, it was moving all the time. So we have what have been set up in the morning may not have been longer applied in the afternoon. It was difficult to keep pace with all the changes implemented within a short period of time. So following an order by the Swiss Federal Office of Public Health, one measure was to limit the consultations with outpatients to a minimum. They told us, okay, only see patients who are really in need of care, only emergencies. But then we had to ask ourselves, what does that mean? Who defines which kind of consultation shall be performed and which ones can be delayed? What does all that mean for ensuring access to reproductive and sexual health care? So these are questions to which you hardly get a clear answer within a context of rapidly changing conditions and while facing a challenge nobody has confronted with beforehand. So, and I think I would like to explore in the following some examples I experienced driven by decision making, and I would like to say it provocatively, what is worthwhile to care for or not in the era of COVID-19 with resources are limited. The dilemma appeared first when I had to advise the assistants at the registration desk which consultations have to be cancelled, which ones have to be rescheduled, and which ones have to get an appointment at any time. While the decision is obvious for a routine gynecological check, I was wondering if I'm in line with the restricted targets given by the Swiss Federal Office of Public Health when I maintain the appointment with a young woman diagnosed with a borderline personality disorder for IUD counseling, whom I perceived as vulnerable. To ensure access to contraceptive information and services for all women during the outbreak, we established a new counseling service over the phone. This was not existing beforehand, and I think, like Michael talked about telemedicine, so far it's not really established. But I think the ethical dilemma is revealed in the micro decisions of everyday life. And to give you another example, one woman reported that several private practitioners, when asking for an IUD insertion for emergency contraception, had rejected her, and she finally ended up in our center. You might not all be familiar with that the copper IUD lowers your chances of getting pregnant by more than 99% if you get it put in within 5 days of unprotected sex. So it's the most effective kind of emergency contraception. What was striking to me that the IUD insertion has been rejected reason by this is no emergency. So bringing me back to the question raised above already, who defines on which ground what is worthwhile to be treated or not to be treated under given circumstances? So in this context, I would like to share another experience with you. In the news, they report about the intensive care unit in Bergamo, northern Italy. The interviewed physician was very desperate when reporting that all the ICU patients are dying, and they ask themselves if they are doing something wrong. So the day after this report, friends of mine decided to no longer welcome anybody in their house because for protecting my female friend who has a metastasizing breast cancer in order to not exposing her to any risk. In their reasoning for this decision, they referred to the Swiss Federal Office of Public Health, declaring persons with cancer are among the high-risk group. So 2 days later, I read the guidelines of the Swiss Academy of Medical Sciences developed for COVID-19 pandemic on triage in case of bottlenecks. As the Academy outlined, the health system and especially intensive care units are facing extraordinary challenges. Health professionals are exposed to particularly difficult situations and be a great responsibility. To provide a basis for such serious decisions, the guidelines were developed. But, however, when I was reading the criteria for ICU admission, my friend with her metastasizing breast cancer would have been excluded and not admitted. Later on, I saw that they have specified it into, quote, malignant disease with a life expectancy of less than 12 months, end quote. So by adding this kind of time frame, this female friend might now be admitted on this ICU. So, and I would like to share a last example with you, which refers to a very controversial issue of reproductive rights, abortion in the era of coronavirus. There's a kind of echo in there. Is it for you okay to listen?
Yeah.
Yeah, okay. So soon after, media reports on restricted access to abortion in the US based on directives seeking to free up hospital beds and preserve the supply of personal protective equipment for medical workers with the postponement of elective and non-essential procedures. This was outlined in the New York Times article. And after that, I received several interview requests by Swiss newspapers. So the journalists were asking, for example, if women still have access to abortion in Switzerland. Or they asked, if we offer all-in-one visits to reduce the patient and clinician's risk of acquiring the virus. Or they are asked if we offer now medical abortion up to 10 weeks of gestation instead of 7 weeks to avoid surgical abortions under COVID-19, with the journalist hint to another Swiss hospital. So I think we only can wonder if this hospital the journalist is referring to may have taken advantage of the pandemic by introducing a new regime. So, however, early medical abortion is the routine treatment option for pregnancies up to 10 weeks gestation, unless this is not safe or suitable for a woman. So outline questions again revolve around which kinds of healthcare interventions are essential to be provided or not to be provided in the era of COVID-19, but now aggravated by the controversial discourse around abortion. Moreover, these questions by the media are touching issues like an exploitation of the COVID-19 crisis to further an agenda that restricts access to essential sexual and reproductive health services, particularly of abortion. And just to conclude, in response to the COVID-19 pandemic, healthcare institutions and professionals are exposed to make decisions they are not prepared for. For myself, facing these challenges has induced a valuable process of reflection. It brought my attention to who has the power and what skills and references are needed to decide about issues of individual rights versus preventive measures to ensure equal care, justice, and such as reproductive rights in times of corona. However, next Monday, the restrictions for hospitals will be lifted in Switzerland, and it will be interesting to see if patients will be back there, because today hospitals here are not perceived as a location of care. Instead, they are perceived as a location of increased risk of acquiring the virus. So I'm curious to see.
So thank you, Sylvie. There's been a lot of wonderful material put on the table here. I think this has been even more interesting than I could have imagined. I'm going to ask Michael to say a word and Mary Jo to say a word, but before, I want to ask Antonio to say a word or two about one phenomena that I know if Alistair here, he would talk about. So Alistair works in a private psychiatric hospital and has had patients in the psychiatric hospital who are both psychotic and COVID positive, which has caused a huge dilemma. And the Department of Mental Health, the DMH of Massachusetts, has essentially refused to allowed those patients to be transferred into standard COVID units, and it's caused a real set of problems, including having to close down entire wards, and thereby beds that used to be opened quite rapidly, people end up being in quarantine for 2 weeks in that psychiatric unit. And I know that, Antonio, you've also had some experience with people who are both psychotic and COVID positive, and I wonder if you would just say a few words about that. You need to turn your mic on. Yep.
So one situation that like physicians, at least physicians have observed, or even administrators, is that at least during this period of time, there has been this kind of degree of refreshing flexibility between institutions, right? I mean, for example, Medicare has suddenly accepted, that, yeah, telemedicine is okay, to see patients in situations like this. Before there were a lot of kind of restrictions. There were, JACO, also a lot of restrictions about what, how a unit should be run. But interestingly, DMH has been the only institution that basically is right now, don't ask, don't tell. I mean, she, DMH requires many specific, I mean, for the rights of the patient, kind of the very specific rules of how a unit should be run. The patient should be able to communicate with others, should be able to kind of, to have access to the phone, has access to the TV, and so so that has to be, no matter what, has to be offered. But then the situation happens that yes, there is one patient, for example, in our unit that became suddenly positive, and the thing is that immediately by I said yeah, here we have to, the unit has to be in quarantine, the patients have to be in their rooms, and the thing is that, but that went against what DMH was saying. No, these patients have the right to still watch TV, and there is only one TV, when we kind of insisted, say, can we really do this? Can we accommodate? Can we allow? Or there was, at least from DMH for us, there was no answer. Don't ask, don't tell. They didn't say, go ahead, do what it is the most kind of likely, what it is more reasonable, more clinically indicated. It's going to, So the thing is that the unit decided, with the administration of the hospital backup, that what happened is that there was also some changes in the hospital. My unit, I mean, it was becoming almost, I mean, there was one patient getting infected, and then there was a staff member, 2 staff members that became infected. And every time one person gets infected, you have to have 14 days of quarantine. So basically, when we were at the end of the quarantine of one, and a staff member got sick, and then we had to extend. So basically, we could not admit anybody, and they were in isolating rooms. And the thing is that, I mean, it was kind of, I don't know, we asked DMH, is this okay? I mean, DMH did not answer, did not say, that's okay, go ahead with the, but it's interesting, what happens, I don't know, for example, we are in a geriatric psychiatry unit, but I don't know, for example, in an acute psych unit, what happens, I know that there was a patient actually that I saw in the medical floor yesterday that needed to be admitted, definitely needed to be admitted in a psych unit. It was a younger person and needed to be admitted. What happened is that unit that took the patient had required that the patient goes to the COVID floor for 2 days, just to be sure that before going to the psych unit as a way of screening them, the patient, to be sure that he doesn't have any fever or anything like that. But in some way, everybody has been very flexible in terms of the rules. I mean, at the end, we had to close my unit because my unit became, I mean, the hospital needed a place for the terminal patients with COVID to die close to the families, you know. And my unit, since we were discharging, we could not admit anybody, and we were within quarantine anyway. So they said, you know what, the 3 patients that you have, send them to medicine, and you continue to follow them over there. The other ones, send them home. You know, is there anybody out of control with behavioral problems? No. Okay, so they are now boarding in medicine. The few patients, you know, are now boarding in medicine with a 1-to-1 sitter, you know. But I don't. But to tell the truth, I don't know what DMH will say about it. They would, you know. I don't think that they are not willing to say, you know what, it's understandable. They are just silent, you know.
Mm-hmm.
Yeah. But I don't know if that answer. I mean, I would be more, you know, kind of curious of what is really happening in a place like, you know, like the one that Alice there works, because it's like
right. So
you know,
hopefully Alistair may be able to join us next week and carry this on.
Yeah.
Lizzie has been trying to make a comment. She wrote a chat and also had her hand up for a moment to talk also about issues of translation, which I think fit into this kind of conversation we're having. So Lizzie, do you want to say a word?
Yes, I do, briefly. I wanted to say that, well, I'm an anthropologist and working as a medical interpreter right now at MGH in Boston. The encounters that interpreters have gone from 300 to 600 to 900 a day.
Mm.
At one point, not long ago, 40% of inpatients were non-English speakers. I've been coming here every day and also working at the emergency department. I'm quite surprised by how well they're fostering the communication between patients and families through iPads and such. And I've never heard somebody speak in a very hurried way to get things done. Here and there in triage, I have seen somebody, you know, write down what they think they heard that wasn't. And I've been able to correct it. So it's very well organized. I've always been critical. And the collaboration, as Michael mentioned, is tremendous. Now, one question I have, well, we have been given increasing protection. I used to go to the ED 2 feet away from a patient with just a surgical mask and, you know, fought to get the N95 and a scrub before I do that. But, you know, there was some discussion here in Massachusetts about having to make decisions about who to re-intubate or who to intubate. I was wondering if anybody also had some information, further information on that. Thank you.
Great. That's terrific, Lizzie. I'm going to ask Michael and Mary Jo to make any comments they want, and then we'll start opening this up more.
I don't have many specific comments to make except just to say thank you to all of you. These were really extraordinary reports and quite profound, and it's going to take me a while to process everything that was said. I thought I'd just flag maybe 2 or 3 things that I'd like to hear more about, but actually I'm wondering if some of you who are clinicians want to ask questions and redirect questions more as sort of kind of a crosstalk. But first of all, I just wanted to flag and see if people had more things to say about Antonio's really extraordinary comments about the internal dilemmas that clinicians have, his notion of the fear and at the same time the beauty of dealing with these kinds of fears that are circulating sort of unconsciously and consciously, and how one deals with that. And in connection with that is the other side, which is I'd love to hear more about this comment, because one hears about this from war situations as well, that people who are depressed and who have other mental illnesses in times of extreme social pressures do better. And I wonder if one can say more about that, sketch it out a little bit further. So the second thing that I found really interesting were particularly from Katie and Iman, both the sense of the tremendous amount of pressures that the nursing staff in particular is under, but everybody who are in the hospitals are under, and the degree to which one has to make decisions on the fly, learn quickly, but also, and Iman was particularly good about this sense of anticipation about what's going to come next, particularly in Georgia, where things are beginning to open up now. And then finally, the third thing that struck me as really important to try to flesh out a little bit more was Mike Nathan's point about the population that he's dealing with, of the undocumented, and how one deals with them in a situation of the spread of a virus that they're of course a little bit resistant to coming into institutions to deal with. But I think I'll leave it there with just those comments and say again, thank you all. Mary Jo?
Okay, I just, I'm very glad that you put those things on the table, Michael, and I thank you all as well. I would like to actually hear from people who would like to ask questions and get the conversation, since Michael set out some very interesting things. I was thinking about how we're living in this time of a work time where space, place, and the pace are of what's happening is so incredibly rapid and different and in a warped sense. So Iman talks about the space travel and things of that sort, and how much she loves this new challenge. So I think that I just think all of you were incredibly profound, and let's hear some cross conversations going on and questions. Thank you very much.
So in the chats, Michael Nathan said there's one thing he wanted to speak to, and then I know Melissa wants to ask a question.
And before that is David Jed Schwartz. So I just want to put in a note on that. Please feel free, everybody, either to raise your hands, like the button that, raise hand, or send a message, a chat. You can send it directly to the host, the co-hosts, or wherever you like, and then put down your name and we'll come to you so you can get a chance to ask your questions.
You can also put in the chat to everyone, and raising hands you do through the participant. At the bottom of the screen, there's a participant list, and you should be at the top of that list, and there's a tab where you can raise your hand. I guess I'm speaking first about the crisis management. So about a week and a half ago or 2 weeks ago, there was a negotiated ethical, it's been working for a month, but a statement was produced that was sort of how we were going to manage if we ran out of ventilators or beds, a way of assessing people's likelihood of benefiting from care and potentially refusing care to some portion of people if we had to choose. that was going to be independent from the clinicians. It was going to be something like what our Optimum Care Committee does, which is to try and assess independently what the benefit or disadvantage is in the appeal process. And the most interesting thing about that to me was that some of our residents and our disparities folks raised a flag that there was a potential, because comorbid diseases like diabetes and heart disease disproportionately affect underprivileged populations, that there was an implicit bias in the ranking for people because their risks were higher to begin with. And no particular solution in sight, but very important to problematize. And it's really difficult to think about how we would manage that in the setting. Do we use procedures that are unlikely to benefit somebody when somebody else is more likely to benefit? How would we account for the fact that they're from a underprivileged, not even minority here necessarily? And that process was negotiated not just for the hospital, but that's a statewide process.
And I think Lissy's comments brought that home in a very special way also. Sadek, why don't you monitor the chats and monitor the raised hands and go ahead and call on people in order rather than my trying to do that.
Yeah, sure. Okay. We have 3 people right now, but we can just go in order. David Jett Schwartz, Melissa, and Nathaniel Tran. So let's go with David.
Hi, can you hear? You can hear me?
Yes. Yes,
yeah.
we can.
Good. I just wanted to share a story from my past. In about 1980, in the spring, I came down with a very bad case of pneumonia, which included a terrible compulsive cough that was from my gut, and it was very painful. And antibiotics did not work. I eventually had to be hospitalized. And they put me on an IV, and the nurse who administered the IV was unable, had to stab me in the arm, like multiple times in order to get it in correctly. And I was doing very terribly. And the only thing that brought me out eventually was a visit from a female friend who happened to have the same 2 first names as the woman who had whose failed relationship had knocked the bottom out of my psyche in the first place. But this woman had no sexual interest in any men, as far as I could tell, certainly not in me. But the point was that she visited me, and that was terribly helpful. And the reason I'm mentioning this is because most of the patients that we're talking about are being isolated from family and any people that they have any emotional relationships with. So that it's possible that if, for example, a patient was asked, is there, or family members were asked, is there anybody from whom a letter might raise the individual's will to live and spirits, that might be a constructive wrinkle in the treatment procedures that best practices that we have that we have been following. That's pretty much the extent of my.
Thank you so much, Jed. So it's Melissa next.
Melissa
right?
is next. Yes. Yes, Melissa.
Oh, hi. And it's I had a couple of questions actually. I mean, we share a pod here. So
you used the Trojan horse, did you?
Yeah, right. Yeah, it's a trick. It's a trick. Send Melissa further ahead. So no, to whomever among our physicians here present would like to respond. I hate to be. I hate to bring things down to very crude things, but this is something that I've been asking myself over these past weeks, and I haven't seen much information about this in the news. Two things, very basic, I think. One thing, especially only in the United States, applies only in the United States, particularly after reading how much of the African American population is hit by this, assuming that probably they will not be, many of them will not be probably covered by insurance. So who's paying for this, for these extended period of hospitalization and an extremely complex bouts of treatment? For those who do not have insurance, how does it end? Because yeah, they survive COVID-19, and what happens then? They go bankrupt, or what happens to them? If they have insurance, do insurances cover a complete treatment that probably passes through ICU, passes through days of intubation and ventilator, maybe passes through induced coma, save a life? From the financial point of view, which then, of course, impacts the social viability of a person who recovers, what happens? Number one. Number two, how many, and this is also something, a data that I couldn't find really in the news, how many of those who are who undergo treatment in an ICU with a ventilator, for instance, so who go through severe complications, how many make it and how many don't make it? Because this is something that came up in Italy a lot. They couldn't find a reason. They couldn't find quite a reason why there was so much catastrophic impact in Lombardy, for instance. But it wasn't clear whether it was a logistical problem, not enough ICU beds, or it was a matter of mortality rate and aggressiveness of the disease, so to speak. We have enough ICU beds, and also those who do end up in ICU with a ventilator don't make it at a high rate, which makes somebody understands better, I think, where the problem might be. Of course, it's not either one or the other. It might be a mix of these things. But you know, New York City is a case in point. Logistics against the deadliness of the virus.
Okay, Byron, question: do you think we should go around and collect questions, or would somebody like to address these? How do we do it?
Oh, and also the Native American. Michael Nathan is also reminding us. No, the Native American population are going to be slammed, even much worse than the African Americans. And air ambulances instead of normal ambulances in the Navajo reservation in Arizona, which we know about. I mean, these are going to be tens of thousands of dollars for each.
So I would suggest.
We have 3 more people waiting for their questions, so I don't know how.
Yeah, why don't we get those questions out and then come back at as much time as we can give to it.
Okay, so we have, who do we have? Nathaniel, Iman, and Katie. So let's go in that order.
Nathaniel.
Hi everyone, I'm calling in. Thank you for this. I was lucky to be a student in Boston, and I've never had the chance to attend the seminar in person, but I'm grateful for this opportunity. My questions, I work a lot around HIV, and I think that there have been, is everyone able to hear me?
Yes.
Yeah.
Yeah.
A
Thank
bit
you.
choppy, but we hear you.
Oh my God, that's asking to start video. Here we go.
Do you have a video?
Hi everyone.
Oh, there you go. Okay.
Hopefully,
Hi.
there we go. So I work a lot around HIV, and I'm interested in these parallels around stigma, behavior change, a search for a vaccine, and the structural factors that have been so pervasive to HIV work 40 years after the epidemic in the United States and enduring disparities. I'm worried about how those enduring disparities unfold here in the United States. So I don't know if that resonates with anyone, or if anyone does want to comment on those parallels around different types of epidemics, different pandemics that have unfolded so differently. Thank you.
Okay, great. So Iman is next.
Okay. So I
Yeah.
actually wanted to address a question that Dr. Schuster asked, and that's about whom should we intubate? And I have a dilemma and an experience with that I'd like to share in response to her question, which is at the big things weren't the same since the beginning of addressing the disaster from now. I mean, things change all the time. But I remember in the first week when we only had 5 beds actually of ICU, and now we have a whole floor of ICU patients. But there was a situation where there were 2 patients and they kind of both needed to be on the ventilator, but we had one. And I will never forget, that's when I felt that we are working in disaster mode, because in a disaster, you don't save necessarily who needs saving, you save the person who's more likely to live. And that's the decision that the doctor made. And it gives me goosebumps every time I remember that, because he put on the ventilator the patient who had the more likelihood to live. And it was a good decision, but it was a little bit hard to take. But that's one thing. And the other thing about intubation is this disease, I've never seen someone who moves from like breathing a normal rate from 12 to 20 breaths per minute with an oxygenation of 100% to drop needing like 15 liters of oxygen and being on a ventilator in less than an hour. It's just, I haven't seen it happen that fast before in certain patients. And so what Emory did is they give instructions to all nurses. The patient comes on 6 liters of oxygen. His autosat is 85, so he's not reaching the 100% oxygenation. They intubate. So you keep hearing like anesthesia alert, and you know someone is getting intubated, because they don't wait until the patient would require a ventilator or ICU. And they discovered that a golden ratio is after 6 liters when they are on their way down, that if you keep them down, it will be very difficult to pull them up. So 6 liters, they're still in the 80s, we intubate. We don't wait. So that's the formula that at least Emory came up with. And the last thing I want to address that she also mentioned was about elective surgeries and chemotherapy. And in oncology, again, I had lots of ethical issues with that. Like today, last night into this morning, I was seeing a patient who it was bad luck that he has an operation right before the whole physical distancing happened. And because of delays in his chemotherapy, actually, he had penile cancer and it's just moved to the bladder, and now it's close to the liver, and he's barely 50. And it's just, you're looking and you know that these delays and his status is because of those delays that happen. And all those patients who were diagnosed and then they considered, oh, cancer surgeries are elective. And then we're in an oncology unit, we never think of cancer or surgical oncology as elective, of course, because we are in it. But that, as Dr. Schuster mentioned, in some cases, as a matter of fact, in the United States, I just discovered that actually oncological surgery is elective, because, and I was like, okay. So that also took a while to put back in place. And I guess Emory started just as of end of last week to do some oncological surgery. And that's because a group of us really advocated and pushed hard to just convince the institution that cancer is different. Like, the day makes a difference. Usually the surgeon, as soon as he sees cancer, he wants to operate ASAP. And so we were able to make that difference and convince the institution that this is, yes, it's elective officially, but we cannot afford waiting. Again, the infusion centers, because of physical distances, there was a paralysis for a good 2 weeks, and people weren't able to get their treatments. And talking about anxiety and mental health, that was very, people ended up inpatient because I think they had episodes of anxiety, ended up with short of breath. I'm not getting my treatments, and all this anxiety that this one treatment that they're missing is going to make the difference between life and death.
Thank you, Iman.
You're welcome.
Thank you. So we have one more comment also from Katie, who wanted to talk about beauty, I believe, and the fear and beauty before we go back to the panel and see.
Yeah, I'll be really quick. I want, and me, unfortunately, since I'm not the expert on that, Nathaniel, someone to answer Nathaniel's question. I just want to comment on, you know, the kind of dichotomy of the fear and the beauty. And, you know, there's a lot of examples of beauty in the hospital with people making exceptions to the no visitor rule and things along those lines. But one that I thought was nice that actually was kind of a combination of the hospital and the community, which as intensivists, we don't ever see our patients when they're well. Like we don't have a clinic, we have no continuity. Like we have continuity with kids who come in all the time and we know them well, but once they leave, we don't see them again unless they come back in. And so we had a family, we had a patient who had been in the hospital for more than a year in the ICU. She couldn't leave the ICU. It was either ICU or rehab were her two options. And she kept on having a lot of different issues. And she actually was getting pretty close to going to rehab, and she was doing as well as I've ever seen her do. She has a lot of chronic medical issues. She was somewhat delayed. She was a teenager. She had a lot of heart disease. And she actually died last week very suddenly. She's probably the one person on the unit that people did not have on their radar as someone who was going to die. And her death had nothing to do with COVID. But her death does have nothing to do with COVID because it's hard to have, as we've all read about in the newspaper, it's very hard to have a funeral or any sort of kind of bereavement ceremony in that setting. And we've actually oddly had a lot of, you know, in the adult world, obviously people die in the adult ICU at a not large frequency, but not small frequency. Kids don't tend to die very much, period. And they certainly don't tend to die a lot in the ICU. The average mortality is around 2% per year. And so, but we've had probably 2 deaths a week in the last month. And all of them have been un-COVID related. So I mentioned that because they're all chronic kids who have a lot of family and caregivers. And I just wanted to read this one email to you. Obviously I won't tell you the name of this patient, but basically the patient's cardiologist wrote to all of us on the ICU and said, he said, spoke to mom today. They are having a small family service next week. The parents had to quarantine because for 14 days, just because they were in Massachusetts. The community, community has not seen this child for at least a year, probably longer, because she was in rehab before then. So the community did a drive-by car family on Tuesday to honor the patient. Her teachers and classmates, police, fire, and ambulance from their town, friends, and neighbors participated, many with red balloons. Mom said there were more than 100 cars. It was an unforgettable experience and very positive for her son. She is very sad they can't have a regular funeral, but the support from the community was unexpected and very comforting. I thought that was amazing. You know, like I've known that girl for a year, but she's not someone who came back and forth. She just had been there for the year. So I never knew anything about her outside community other than her parents, who I've spent a lot of time with. And I just thought that was an incredible, really supportive way that's both related to and not related to COVID. I just thought I would share that.
Thank you. Thanks very much.
You.
I know we have one last question, one last person who had requested, Dawn. Dawn, would you like to ask your question quickly? We do have a few minutes.
Sure, just very quickly. Hi, everybody. I'm also here in Atlanta, and I'm a medical anthropologist as well as a rabbi. And in the latter capacity, what I have been seeing a lot is people with different levels of mental illness, depression, anxiety, suicidal ideation, needing help to figure out how to get out of social isolation. And we've been trying very hard to figure out how to balance the need for social isolation and the need for some people not to be so socially isolated. And it's been relatively ad hoc. One of the things they're complaining about is the severity of messaging that's coming out, not even so much from public health, but from civil society and social media that really stigmatizes anybody who feels like they need to find a company because they can't be alone at a given time. And I'm just curious what anybody has to say about that.
Great, thank you.
Antonio, yeah.
Can I was just trying to answer some of the questions that that were raised. I mean, there is a question raised also by Michael, who asked, how do we see that these kind of people with depression, that they may feel, at least temporarily, if not on the kind of long term better, And one thing I was thinking was about a book that you probably, some of you may know, Nasir Gaemi. He's actually the mood disorder kind of a chief in Tufts, but also he is a philosopher. But he wrote a book called A First-Rate Madness, and then he talked there about how some leaders with mental illness and especially depression may have been actually good leaders because they suffer from that. Like talk about Churchill in particular. How Churchill was alcoholic, he was depressed, but when it came the time to kind of lead England, like his depression helped him to be more realistic and not let's say not freaked out. He already had the experience with that and resilience and probably some empathy and even creativity that in other moments other people will be like so kind of out of shape that could not do that, versus somebody that has the experience of dealing with it in some way. I think that get better when they see that there is a crisis mode in. But one thing that I think makes a difference is that if that person really can make use of those kind of abilities, again at the beginning of this kind of when everybody started to be confined, from almost every patient that had depression and anxiety in my practice, all of them were better. But 3 weeks later, probably from those, they are not, why? From there, probably only, only about 2 or 3 remain like that, two or three remain like that. And the reason for that is that the people that got this immediate were people who were isolated, but somehow connected with others, either family members or friends, but call them and they were able to offer some insights that they already have known because of their illness, the calm and the creativity, a creative answer in that case. But unfortunately for those patients, actually, if they continue to be isolated and without any particular task, that deflates and goes back again to even greater despair in some cases, because now there is no connection, even that initial connection disappeared. However, there are some that actually got into tasks that they were given. There is one of my patients that now has been using her dog as her therapy dog, as to say hello to from the windows to every people walking, and then everybody's like getting out, just to say hello from the windows, nursing homes, and everybody the residents say hello. And for her, that has been a kind of renaissance for her. It's like for her, like it's something that I think, and then I think she will continue with this project, which have been very important, But so I don't know if that has to do with it, but it looks like for some people, depression, in fact, can make them more realistic and more calm in moments of crisis, And I don't know, that's one idea I have. But and then the other thing is that what I found with the ethical decisions regarding Iman and the ethical decision regarding who is who gets receive ventilation. It was interesting that in my institution here in Beth Israel, Lehi, big thing, actually that the leaders started to bring that up. The situation have not gotten to that point, but already 2 or 3 weeks ago, they started to bring it up as, hey guys, you know what? We may encounter this dilemma. We appreciate your comments, please. So it's like, we are not in that, but we appreciate so opening some kind of discussion, which I think that at the end with ethical decisions, there is no right or wrong. It's just, if you have been discussing, at least if you have heard every point of view, I think that is the correct thing to to consider. I mean, and so that feels good in some way. I think that was very smart from the leadership to start to kind of include, and the other thing is that there are so many things that, have been so invisible or at least avoidable to decide, which is, the issue of disparities, these disparities are there. I mean, now they are kind of becoming evident. And the thing is that, I mean, to Andrea's question, what is going to happen after this? I mean, right now it seems that COVID-19 is being subsidized in some way. So either, by insurances, but then the government will help them, or hospitals, they will not kind of go bankrupt with this, and patients will not get charged for this. But the truth is, like, afterwards, what? I mean, this is going to be like in shambles, the whole system. So, but then it's going to also bring up, like, wow, I mean, we cannot be, the way we were doing before. I mean, this pandemic is not really a contingency it's not a situation that is kind of very occasional. We know that it is part of the human experience, and it will continue, and it will happen and occur again in some other way. So in some way, that's part of our, or who we are, as part of nature. So it's like I think it's breaking all this kind of arrogance about what we think we are, greater. We have conquered nature. No, we know we have not. I mean, we understand some things better, but we have not conquered anything. I mean, it is, and in some way, it's like come on, let's be humble. So in some way, it is so an opportunity that, things that are overlooked, and at this time maybe we will not. And finally, I just want to recognize, I mean, Iman, when.
Sorry, just one moment. I'm going to let you continue. But since we're over time, technically, I just want to check in with Byron, Mike, and Mary Jo and see, would you guys like us to keep chatting for a while, or what do you suggest?
What I would like to see is Antonio conclude with this, and then perhaps we could end formally and carry on the conversation next week or the following week, and invite people to email, and we'll set up some other times as well.
Okay.
And because so much has been put on the table, but we've gone for 2 hours now.
Okay.
Yeah.
Okay.
So Antonio, if you could conclude with fear and beauty. And
well, I mean, the fear and beauty, but also I would say the other is that, the disparities that are coming up. And I want to say that also it's becoming very evident in the, the experience of Imam as a nurse. The thing is that there are these differences also, that you see this, hierarchization in the specialty. You can see, that, yeah, I am afraid, but I'm not there. I'm not there taking care of the patient. I'm not doing the, aspiration, I'm not doing like changing the patient, I am not touching the patient, or I'm not touching the patient. The thing is that, and versus the nurses are there, the personal care attendants are there, and they are the ones that are at greater risk. And there is this kind of, I can imagine that, this is something that is not as spoken, but I do notice this, I mean, a little bit of, resentment in this kind of, we don't talk about that at all, but there is always a resentment, a little bit from the nursing part, because they are really the one doing this stuff, and we are the ones that are kind of writing the order. And it is something that also, how to, so at least to be open in discussion, because it is true. I mean, and also personal care attendants, the people then at the end doing the cleaning. I mean, they are really the heroes, but I have no idea. They are the ones that at 1 a.m. picking up, the the trash with all the contaminated material quietly, bringing there is, you know, nobody, nothing, the lack of recognition, the lack of visibility of something that is so crucial, you know. But anyway, that's what I'm finishing. But
So
I just wonder if, Mary Jo,
yeah.
I just wonder, just to put on the table for next week, not for now. There was this medical school statement that was put out by George Daly and Bob Trug and others that was in the New York Times or the Globe, I can't remember which, about setting up an ethics commission to think about how to make some of these ethical decisions, particularly about triage. I wonder if anybody knows anything about that. And I wonder what the connection between that level of discussion is and the kinds of on the front line, everyday decision-making that Iman and others are having to do, if there's a disconnect there, or if somehow there's a connection between the two. But to be continued, and once again, I just really want to thank everybody. This has built an extraordinarily rich discussion, and to be continued.
Byron.
Thank you. Thanks, everybody.
I think
Can't hear you, Byron.
Yeah.
Unmute.
Unmute Byron.
I was just going to ask Sylvia.
Can't hear you.
Can you unmute Byron?
I'm unmuted.
All right.
Okay. You can't hear me?
Yes.
Yes, you can.
Okay, Sylvia, I just wanted to, because everyone else has had a last chance to come back in. Did you have any last reflections also, Sylvie?
Maybe she's already gone.
Is Sylvie there?
Oh, she's there. She's there.
I'm there. Thanks so much. I'm just wondering, because you said, because Michael was coming up now with talking about the decision making, and you know that you create a kind of ethical committee, right?
Well, they've been preparing, yes. And the idea, and the idea of having committees on standby to help think through these things who are not the actual attendings.
Because I think this was something very striking here in Switzerland and Germany as well, because when they were really short of ICU beds and ventilators, I think there was a very hard discussion. What is really valuable to, you know, like Iman was talking about it beforehand too, you know, what is, for sure you have a triage and you have to make a decision what has, you know, the best chance to succeed. This is always clear. But when you have to make a decision about how to value the age of a patient, and you know, and according to another patient which has maybe a chronic disease, so how do you balance that? And I think this is very interesting questions which came up within the COVID crisis. So I'm curious when you talk about it, what I understood next week, right?
So there certainly are a lot of great issues on the table. I think we've hardly taken on the issue of inequality that is obvious in this situation, and one that deserves a longer conversation. We'll work out amongst the kind of steering committee as to exactly how we proceed over the next 2 weeks. But also, so let me just conclude and say thank you for these very rich reports from the field. As Michael said, as Mary Jo said, it's been really heartening to see people, to see you all, to see faces, to hear your voices. And we look forward to seeing you all in next week. Is that enough?
Okay.
Okay, Mary Jo?
Okay.
Let me just add that I have tried recording the session, so hopefully it has worked. I will let you know where you can access the recording if anybody wants to go back to what has been said.
Great.
Okay, thank you. Bye.
Thank you. Thank you.
Bye. Thank you.
Bye-bye,
Bye.
guys.
Bye. Bye.
Bye-bye.
Take care.
Ciao, everybody.
Take care. Bye. Thanks. Bye. Everyone. Bye. Bye.
Sylvia, I hope you can make it next week.
Yeah.
Send emails,
Bye.
conversations. Take care.
Bye, guys.
Take care, Mary Jo. Take care, Byron.
Bye-bye.
Thank you. Thank you. Thank you
Bye,
all for
everyone.
coming.
Bye-bye.